Another important role of the nurse in enteral feeding is transitioning to oral feedings. So it needs to be done correctly so that we can help the patient get back to, quote unquote, normal food as soon as possible, as well as, it's more at a higher quality for the patient to be able to taste food versus going down a tube. So first and foremost, you want to stop the tube feeding for 1 hour before and after meal time. You're going to want to check with your site policy procedures. Some places you need to have an order to do this. The other big thing is calorie counts are very important. So usually while we're transitioning a patient, we might be, for example, giving them tube feeding overnight and then having them eat meals during the day. Or giving another way we might do it if they eat less than 50% of their tray, they get so much tube feeding. Or they might be getting I've had it where they've been getting tube feeding continuously and they're getting trays. And so it can be really hard for that patient to have any sort of appetite because their stomach is always feeling full. So calorie counts are very important because usually when the patient's oral intake exceeds 2/3 of energy requirements, we can discontinue the tube feeding. So we really look at calories and protein intake is what we're looking for. And when we can meet those goals, those outcomes, we can then stop this type of treatment. Other things to consider with enteral nutrition or tube feeding is number one, how do you check placement? Initially, this is tenderly done with an x-ray. The other thing you're going to do as a nurse is you're going to want to mark on the tube right by the insertion site, by the nose, mark it with a black permanent marker, and then measure the tube from the insertion into the nose out until the end. This patient is going to be at aspiration risk, so at very high risk even. So we must check placement upon insertion and prior to administering feeding. You also need to put the head of the bed up at least 30 degrees. I personally prefer 45 degrees because patients tend to slide down a little bit, and that way I still know that they are at least at 30 degrees. However, this now creates a new risk factor because this increases risk of skin breakdown. When you have to have the head of the bed at least 30 degrees, there's now more friction and shearing that can happen on the buttocks, for example. So you need to help decrease risk for aspiration, you actually end up increasing risk for impaired skin integrity. So you'll need to be monitoring that more closely as well. Another very important point is that you cannot increase the rate and the concentration at the same time. What that means is if the order is changed from like 1.2 calories per milliliter to 2 calories per milliliter, I can't also at the exact same time increase it from 45 cc's an hour to 55 cc's an hour. Only one can happen at a time. Irrigating the tube. You want to do this with warm water. You want to flush the tube before and after you give medications with at least a minimum of 20 milliliters. If they're not on any sort of fluid restriction, I like to do more, especially if they have the small bore tube feeding the tube, because that will it's easier for those to clog. If they have continuous tube feeding, they need to be irrigated at least every 6 to 8 hours with 40 to 50 milliliters to keep it patent. You also want to flush with water before and after bolus or intermittent feedings and when the feeding is stopped. We like to use warm water to flush if the tube clogs. If that tube does clog and you cannot unclog it, it will need to be removed and replaced. So we want to try to avoid that by making sure that we're irrigating frequently so it does not get clogged. Oral hygiene, very important, especially if this patient is NPO. Then it's really easy for the bacteria and the yeast in their mouth and fungal infections to go. So we do things like we want to do frequent mouth washing. We can use flavored lip balms. We can put artificial saliva in to keep that mouth moist, and also decrease the bacterial load as much as possible. Excuse me. Another thing we might use is this thing called banana flakes. Banana flakes actually help because one of the common side effects of tube feeding can be diarrhea. So if we've ruled out C. diff, which is an infection, we could then use banana flakes, which are just what they sound like. It looks kind of like brand cereal. And I have a picture, it's right here. It just comes in this little pouch. And you mix that with water. And so it's going to help decrease the diarrhea, help bulk up the stool more. But again, we cannot do this until we know the patient does not have some sort of infectious diarrhea, because keeping infectious diarrhea in the bowels longer is only going to make things worse. Last thing on this slide to really consider is bacterial contamination. So that's why in the hospital we use the closed system. Tubing needs to be changed every 24 hours. In the hospitals we use these free pre-filled bags. You can see one right here. At home we may use cans. You're going to need to read the label for how long it's able to sit out. It's usually no more than 8 hours and can be refrigerated for up to 48 hours. One of the biggest things that always help with contamination is washing hands. So you want to wash your hands prior to handling. This is just a clean technique. It is not aseptic because we're going to the GI tract, but we don't need to introduce anything either. All right, let's go on to parenteral nutrition. So this now is we're using the IV, and again, we're doing TPN, total parenteral nutrition, which means we're using some sort of central line that we saw earlier. This is very expensive. It can be easily 10 times as expensive as enteral feeding. One bag is used per day, and they easily cost over $1,600 every day. At Aurora Healthcare, where I also work, it's considered a medication and it's administered as such. Fats are going to be given as piggyback, which you can see in this picture. This bag, this bigger bag right here, is actually the total parenteral nutrition. It has everything specified, like how much potassium should be in there, how much carbohydrates should be in there, how much magnesium, how much vitamin C should be in there. Those are all mixed up individually, and they're ordered to have a very specific. If you look at the list, it's going to be a long laundry list on here of what's exactly in here. Then this one over here is actually the fat. So these two can't be given together in the same bag. So instead what we do is we piggyback this fat. So both of these go through the pump on its own, and then we white pour them together underneath. Before initiating the fats, we're definitely going to want to get a lipid panel prior to initiation. Because let's say in 2 weeks we check the patient's cholesterol and the cholesterol is 350. How do we know if it's the fats that we've been giving this patient or if they already baseline had elevated cholesterol? Here, I already made this point right here. Now, another thing to consider is that this patient is at risk for hyperglycemia. There is at least 10% dextrose in this solution usually. So we are going to be checking blood sugars every 6 hours at a minimum. How this is typically initiated is let's say again, just like we had with enteral nutrition, we have a goal rate of, let's say, 80 cc's an hour. Well, when we first start this, we're going to start at half the goal rate. So this one's different. The other one we started at 25 cc's an hour, doesn't matter what the goal rate is. This one via IV, we're going to give it half whatever the goal rate is. So again, let's say that goal is 80 cc's an hour. I'm going to start this out at 40 cc's an hour, or 40 milliliters an hour. And then I'm going to check the blood sugars every 6 hours. 12 hours after this has been initiated or started, if the blood sugar is less than 180, then I can increase to the goal. So then, let's say I start this at 7 a.m. At 7 p.m., the blood sugar is 145. I can then increase the rate to 80 milliliters per hour. Prior to initiation, we want to get baseline vitals and baseline labs. So we want to definitely get a baseline weight. And then we're going to talk about what labs do we need to get at a baseline, as well as what do we need to get to continue to monitor. We monitor blood work a lot on this patient. So I already mentioned we're going to be doing blood sugar checks every 6 hours because of that high risk for hyperglycemia. We're also going to do electrolytes because if there's a whole bunch of electrolytes in here, I'm going to want to make sure that they're not going hyperkalemic or hypokalemia or all those different things. I'm going to be looking at their total protein, their prealbumin, their albumin, their BUN and creatinine to make sure that this is not causing them to go into renal failure. I'm going to be looking at LFTs, which are liver function tests, to make sure this is not too hard on the liver. I'm also going to be doing a CBC, which is going to be a complete blood count, which is going to tell me their hemoglobin, hematocrit, as well as the red blood cells, white blood cells. And then lastly, as I mentioned already before, I'm going to be doing a lipid panel. All right, and then let's talk about how do we know when this is effective. So what we expect to see here, or what our goals would be, is that we want a daily weight gain. The highest we'd want the weight gain is a kilogram a day. More than that is going to be fluid. Remember that. Um, we also want to be looking at their albumin and prealbumin, especially the prealbumin. That's going to be showing us short-term changes. We want to see both of those numbers rising into the normal range. Other things to think about is, I already mentioned this before, what do we need to get at baseline? We want a baseline weight, a baseline BMI. We want to look at the nutritional status in those labs. Those are things we're going to get when we start as well as ongoing. Then we're going to do patient education. What do you think are some things that the patient might need to be educated on? Are they going to go home on this? Is this possible to go home on, for example? Why are they not able to eat, or should they eat? We do like with TPN, if possible, even to have them take sips of water or juice to keep that GI tract working, even though, unless they have something like a swallowing difficulty or some reason that they absolutely cannot swallow. If we can, we do like to at least put a little bit of something through their stomach still to keep it working. Another thing too that's important is we have to use this special type of filter. It's called a micron filter. This is going to make sure that that the lipid that anything is not too big of particles are not getting through into the patient, into the bloodstream. It's very important to monitor your flow rate because if it's too slow, then the patient's not going to be getting their necessary nutrients. If it's too fast, this can lead to things like dehydration, hypovolemia, shock, and even death. Then there's complications that we're going to want to worry about as well. We're going to look at things like hyper or hypoglycemia, hypoalbuminemia, hyperkalemia, hypophosphatemia, hypocalcemia, which is said in layman's term would be high or low blood sugar, low albumin or low protein, high potassium, low phosphorus, low calcium, and then also dehydration and fluid overload, because if they're gaining more than a kilogram a day in weight gain, that's really fluid overload that's going on there. So those are really going to be all those metabolic complications we're going to be monitoring for. Now, one other thing I forgot to mention up here is, again, this is actually, we talked about it being clean technique for enteral nutrition. This needs to be sterile technique with big changes for total parental nutrition, because we're going into the bloodstream, which is a sterile technique. This slide right here is really just to remind you again, what is the normal albumin and prealbumin, and what do they mean? Because I just wanted to really remind you of this so that you don't forget, because you will need to know these lab values for the final. All right, now lastly, let's talk about what are some potential barriers to adequate nutrition. So here I have a list for you of all the things that, according to ATI, can be barriers to adequate nutrition. So definitely poor dentition. So whether it be that they have dental caries, like especially in the children, when we look at that, that's why we do things like we encourage use of fluorinated toothpaste, sometimes even having fluoride added to their teeth, or drinking fluorinated water to help with dental caries. In the older adult population, we're typically more looking for, do dentures fit well? Are there any sores underneath? Because those can all affect a patient's ability or person's ability to get an adequate nutrition. You know, if I can't chew properly or if it hurts, I'm not going to really want to do that. And actually, any adult who is admitted to either acute or long-term care should really have a dental inspection done by the nurse to see if there's any issues that may impact their ability to properly eat. Next one is food insecurity, or another way of saying that is lack of access or low socioeconomic status. So having not enough money to purchase healthy foods for a special diet can be a barrier just in itself, as well as you know, usually cheaper foods are higher in calories, higher in salt, higher in fat, and higher in simple carbs. The lack of the ability to purchase food can lead to malnutrition and obesity. Also important is the lack of transportation. So if I can't get to the grocery store, if I don't have a license, or if mine's been taken away, that's going to, or if I don't have a car, that is going to be a barrier. If you see these things, we're going to want to do things like encourage frozen fruits and vegetables, which can be usually more affordable but still healthy. Teaching our patients how to read food labels, as well as discussing what are some possible food options or substitutions, and maybe even getting the dietitian involved. We'll have one more slide on the last of these barriers.